So CLL is a disease of older patients. And so naturally in our clinics, we see many patients with a variety of different comorbidities. And certainly the therapeutic decisions we make must take into account the comorbidity burdens of patients. Now, of course, there are many comorbidities that won't necessarily influence therapy one way or another, but there are some certainly when you're choosing primarily between a covalent BTK inhibitor or BCL2-based therapy that will sway you in one direction or another. Now, of course, sometimes patients' disease biology might sway you in one direction or another, and also, of course, patient preference is key. But I think there were one or two comorbidities that are sort of fairly critical in terms of decision making. I think if you've got somebody with particularly bulky disease who's at risk of tumor lysis syndrome and they have poor renal function, you might, for example, want to avoid a BCL2 inhibitor before a BTK inhibitor. Conversely, if you've got somebody with a problematic history of arrhythmias or on anticoagulation with warfarin, for example, because of a metal heart valve or impaired cardiac function or problematic hypertension, then again, you might want to avoid a covalent BTK inhibitor before a BCL2 inhibitor. So whilst a lot of people sort of sit in the middle, there are occasional patients that might push you one way or another in terms of your decision making.